Question 13. Which of the following is a classic clinical feature associated with Pancoast tumors, otherwise known as superior pulmonary sulcus tumors?
Your options are A. Spontaneous pneumothorax, B. Horner syndrome, C. Nonproductive cough, D. Hemoptysis, or E. Pain in the T4 and T5 dermatomes.
And the correct answer is B. Horner syndrome. The clinical mechanism here is absolutely critical. See, a Pancoast tumor is located at the extreme apex of the lung. Because it sits way out there peripherally, standard symptoms like a cough or hemoptysis are frequently absent early on. Instead, local apical infiltration destroys the lower cervical and upper thoracic sympathetic chain, specifically the stellate ganglion. So the crucial takeaway here is the Horner syndrome triad: ipsilateral miosis, ptosis, and anhidrosis. And remember this clinical pearl: direct tumor invasion of the C8 to T1 brachial plexus causes severe radicular pain tracking down the ulnar aspect of the arm, along with wasting of the intrinsic hand muscles. Let's hit question 14. Question 14. We've got a 38-year-old patient presenting to the surgical emergency department in an unconscious state following a motor vehicle collision. The patient's Glasgow Coma Scale score is 7. What should be the immediate next step in airway management? Is it A, administration of intravenous mannitol, B, intravenous fluid resuscitation, C, administration of intravenous steroids, D, plain CT brain with bone window, or E, endotracheal intubation and ventilation?
The correct answer is E, endotracheal intubation and ventilation. A comatose trauma patient with a GCS score of 8 or less completely lacks the protective cough and gag reflexes required to prevent aspiration, which puts them at immediate risk for tongue-base airway occlusion. The old trauma maxim dictates, GCS of 8 or less, you intubate. Securing that airway takes absolute clinical priority over any diagnostic imaging. And this brilliantly illustrates a strict physiological rule too. Systemic corticosteroid administration is completely contraindicated in acute traumatic brain injuries, as it actively increases mortality rates. Moving right along to question 15.
Question 15. A 28-year-old male is admitted to the ICU following head trauma. On the 4th post-admission day, he develops seizures. His urine output is just 500 milliliters per 24 hours. Labs reveal a serum sodium of 115 milliequivalents per liter, a serum osmolality of 250, and a urine osmolality of 800. So what is the diagnosis? A, diabetes insipidus, B, cerebral salt wasting, C, water intoxication, D, syndrome of inappropriate ADH secretion, or E, acute renal failure. The answer is D, syndrome of inappropriate ADH secretion, or SIADH. This is a classic manifestation of post-traumatic SIADH. Unchecked ADH release causes free water retention, which presents as hypotonic hyponatremia and inappropriately concentrated urine. Now, the crucial point here is distinguishing this from cerebral salt wasting. While both present with hyponatremia and high urine sodium, SIADH presents as a clinically euvolemic state. Cerebral salt wasting, on the other hand, is a profoundly hypovolemic, dehydrated state that requires aggressive volume restoration rather than fluid restriction. Keep in mind, severe hyponatremia below 120 rapidly drops the seizure threshold in the brain parenchyma. Question 16. Which of the following electrolyte abnormalities is most likely to be found in a patient admitted with raised intracranial pressure? The correct answer is C, hyponatremia. Driven by either SIADH or cerebral salt wasting, it is the most common electrolyte derangement in neurosurgical patients. But here is the absolutely critical clinical pearl. Standard medical SIADH uses strict fluid restriction. Neurosurgical SIADH, however, especially with subarachnoid hemorrhage, requires hypertonic 3% saline because fluid restriction can actually worsen cerebral perfusion and trigger delayed cerebral ischemia. On to question 17. Question 17. A 39-year-old male patient presents complaining of severe headache and intermittent seizures. A diagnosis of glioma is made. Which of the following is the definitive primary mode of treatment for glioma? A, systemic chemotherapy. B, local chemotherapy. C, highly focused radiation therapy. D, surgical resection. Or E, anti-epileptic drugs along with steroids. It's D, surgical resection. Maximal safe surgical resection is the definitive primary treatment for both high and low-grade gliomas. We do this to debulk the mass, alleviate high ICP, control seizures, and establish histopathology. But due to the microinvasive, diffusely infiltrative nature of high-grade gliomas, complete surgical eradication is rarely a cure. Recurrence is pretty much the rule.
For gliomas in the eloquent cortex, like the motor strip or Broca's area, awake craniotomy with intraoperative cortical mapping is the gold standard to preserve those vital pathways. Question 18. Question 18, which of the following is the best initial treatment option for a brainstem glioma in a 70-year-old male patient? The correct answer is D, radiotherapy. The anatomical restriction here is what makes this so fascinating. Brainstem gliomas are anatomically unresectable because of the high concentration of vital cardiorespiratory nuclei. Surgical entry carries an entirely unacceptable risk of immediate catastrophic respiratory arrest. So, primary definitive treatment shifts entirely to focused external beam radiotherapy, typically 44 to 55 gray, combined with high-dose corticosteroids to reduce that radiation-induced edema. Next up, question 19. Question 19. A 55-year-old man undergoes a radical neck dissection where both internal jugular veins are ligated. What is the expected effect on his intracranial pressure? A. ICP rises abruptly but doesn't fall back. B. ICP rises slowly and falls back slowly. C. ICP rises abruptly and then falls back toward baseline. D. ICP initially falls, but a persistent rise is seen later. Or E. None of the above. The correct answer is C. ICP rises abruptly and then falls back. Ligating both internal jugular veins causes an immediate block to cranial venous outflow, abruptly spiking the intracranial pressure, and this brilliantly illustrates our physiological redundancies. The pressure falls back as backup collateral venous channels rapidly open up to redistribute that drainage. The sudden block literally forces the opening of the anterior internal epidural, vertebral venous plexus, and deep cervical veins. A preoperative CT venogram or DSA is super useful to confirm these pathways are actually patent beforehand. Question 20. Question 20. A patient is diagnosed with an infratentorial or posterior cranial fossa mass lesion on imaging. Which clinical feature is classically associated with this lesion? A. Anosmia, B. Multiple cranial nerve palsies, C. Asteriognosis, D. Bitemporal hemianopia, or E. Acalculia. The correct answer is B, multiple cranial nerve palsies. The posterior fossa houses the brainstem and cerebellum, so expanding lesions compress the local brainstem architecture right where cranial nerves 3 through 12 originate. The crucial point here is remembering the posterior fossa compression quartet: multiple cranial nerve palsies, nystagmus, rapid neurological decline or coma due to acute obstructive hydrocephalus, and cerebellar ataxia. Question 21. Question 21. We have a 40-year-old patient presenting with gradual diplopia, anosmia, ipsilateral optic atrophy, and contralateral papilledema. What is the most likely cause? Is it A. olfactory groove meningioma, B. vestibular schwannoma, C. brainstem glioma, D. medulloblastoma, or E. pituitary adenoma? Correct is A. olfactory groove meningioma. That highly specific combination of anosmia, ipsilateral optic nerve atrophy from direct local tumor compression, and contralateral papilledema from globally raised ICP represents the Foster-Kennedy syndrome triad. This is extremely specific for anterior skull-based tumors, like olfactory groove meningiomas, which arise from the arachnoid capsules right along the cribriform plate. Question 22. Question 22. A 50-year-old patient presents with unilateral hearing loss, tinnitus, and progressive gait balancing problems. What clinical diagnosis should be suspected? A. olfactory groove meningioma, B. arachnoid cyst, C. schwannoma of the fifth cranial nerve, D. vestibular schwannoma, or E. glomus tumor. Correct is D. vestibular schwannoma, a slowly progressive unilateral sensory neural hearing loss paired with tinnitus and vestibular unsteadiness, is the absolute classic presentation of a cerebellopontine angle mass. They originate from the Schwann cells of the vestibular branch of the 8th cranial nerve. And take note, an MRI of the brain with gadolinium contrast targeted specifically to the internal auditory canals is the gold standard diagnostic tool here. Question 23. Question 23. Which of the following is the most frequent cause of a bitemporal hemianopia? A. olfactory groove meningioma, B. vestibular schwannoma, C. brainstem glioma, D. medulloblastoma, or E. tumors of the mid-optic chiasm? The answer is E. tumors of the mid-optic chiasm. Mass lesions compressing the central sagittal fibers physically disrupt the decussating nasal retinal fibers, and that results in a pathognomonic bitemporal hemianopia. Now, the origin of the compression actually dictates the exact defect. Pituitary macroadenomas compress the chiasm from below, initially presenting with superotemporal defects.
Craniopharyngiomas, on the other hand, compress from above, initially presenting with infratemporal defects. Question 24.
Question 24. A patient presents with seizures and projectile vomiting. On a contrast-enhanced CT scan, a ring-enhancing lesion is identified. What's the most likely cause? A. Moyamoya disease. B. Cerebral hydatid cyst. C. Brain abscess. D. Subdural empyema. Or E. Intracerebral hemorrhage.
Correct is C. Brain abscess. This typically presents as a smooth, thin-walled capsule right at the gray-white matter junction, surrounded by vasogenic edema. To differentiate a brain abscess from a high-grade glioma, a DWI MRI is definitive. An abscess exhibits restricted diffusion because of its viscous purulent core. And make a note of this severe clinical caution. While high-dose steroids reduce vasogenic edema in metastatic tumors, they are generally avoided in undrained brain abscesses due to the massive risk of impairing immune clearance. Final question, question 25.
Question 25. A 54-year-old female presents with morning headaches, occasional vomiting, left arm weakness, and multiple metastatic neoplasms widely distributed throughout the brain from breast cancer. What is the best treatment option in addition to corticosteroids? A. Surgical excision of all deposits. B. Whole brain radiotherapy. C. Chemotherapy alone. D. Radiotherapy combined with chemotherapy. Or E. Surgical excision followed by chemoradiotherapy.
The correct answer is B. Whole brain radiotherapy. The documentation of multiple diffuse cerebral metastases severely limits the utility of localized surgical resection. Surgical excision or stereotactic radiosurgery is typically reserved for oligometastatic disease, which usually means 1 to 3 accessible lesions. But in diffuse disease, the definitive protocol is whole brain radiotherapy paired with high-dose dexamethasone, initiated immediately to downregulate capillary permeability and palliate intracranial hypertension. When facing diffuse disease like this, one must ultimately ask, does the short-term survival benefit of whole brain radiotherapy truly outweigh the grim, inevitable cognitive cost?